Good afternoon, everyone, and welcome to week 7 of the 8-week requirements of participation, the training requirements from CMS that were put out on June 29th, 2022. Today's focus is going to be on nurse aide training. And that's me, for those of you that don't know me. The planners, and I have no commercial entities or conflicts of interest to disclose. And the 8 weeks that we've been doing, the first week was an overview, second week was on communication, third week was on resident rights, fourth week was on QAPI, fifth week on infection control, sixth week on compliance and ethics, and seventh week, which is today, November 17th, and we are going to do nurse aide training. And then next week or the week after Thanksgiving, we'll do behavioral health training. And those are your dates. The objectives of this 60 minutes is that you, the learner, will be able to understand the 5 points of really the five points of a nurse aide training program. I put them in the objective because I want you to assimilate the information, that there have 12 hours of a minimum of 12 hours of training per year, that you have an ability to understand and assess if they are competent. They are trained on abuse, they are trained on dementia, and that you do an annual performance review that identifies their weaknesses, and you provide them training specific to their skill set needs. The second goal and objective is for you to be able to understand what it is that the surveyors are going to do to evaluate your efficacy, one of my favorite words, of your education program for your nurse aides. So, for example, they might interview people, they might observe, they might look at your curriculum. And number 3 is that you, the learner, will be able to cite 3 ways for you and your organization to assess, evaluate the competency of the nurse aides. So an example of that would be a quiz, a test, a return demonstration, a post-session conversation like we do. It's one of the reasons why we do it. So those are your objectives. Now, FTAG 947 is the tag for a nurse aide training program. And you can see that not just because I want you to assimilate into your head the tag numbers, and 940 is the overarching training requirements. And then 941, as you can see, you have them on your PowerPoint. So 947 is nurse aide training. So to cite the regulations, it is required that all certified nurse assistants have a training at least 12 hours per year, and that you do a performance eval on them. Now, one of the biggest threads that we've been talking about, or at least those that have been around the country with me have been talking about, is this facility assessment. The facility assessment is the driving factor behind all of this, because remember that facility assessment defines who you are. It's defining the patient population. This 120-bed facility has a 99% occupancy with 75 males and so many females, and with a primary diagnosis of ORIF. You need to define who you are, write it in your facility assessment, and then develop your training programs to fit those patient needs. This has been a long-standing discussion since 2016, and I understand that the facility assessment can be burdensome, and it needs to be updated every November. And don't forget to add things in about COVID and your strengths, weaknesses, and threats, and adding information in about your training programs and things that you're doing differently now because of the pandemic. And the goal is that you have an annual evaluation, a performance review of the employee, and you have a conversation with them about, oh, I think you do really good at this. And maybe you might need more training on how to work with patients with cognitive impairments. But also it's a forum for the nurse assistant, the nurse aide, to communicate areas that they would like to learn more about. I am a knowledge junkie. The more you learn, the less you know, right? And that's why I like the post conversation, because there are always different angles that can occur in a conversation. And it's the respect for the knowledge. But understanding that they're looking at that you are specifically training and you're correlating how you define your facility with how you train your employees. So I'm going to repeat this. So a minimum of 12 hours. And let me be very clear that it probably will be more than 12 hours, because in order to get all the information in, it probably is it will take more than that. So obviously the minimum of 12 hours. You have to ensure the competency. I love the quiz. I love the quiz. I love the Survey Monkey. I love the quiz because it's just that, do you get it? Do you understand it? Do you see the concepts? Is there any big gaps missing here? And I usually put a 70%. And of course, in school, one would say a 70 is a C minus. But, for that driven academic kid that I was, I always say, well, shoot, if I get 7 out of 10, that's a lot, so I'm not going to, I don't want stress. I don't want to stress people out. Dementia training. Dementia training is a big one we'll talk about in the context of that. There are some states that require it. They require it if you have a specified unit. There are some states that do not. There is an underpopulation of healthcare providers in that sector. And coupled with the existing staffing shortage, it's even a higher risk. So dementia training and abuse training, and we're going to connect the dots between those. And obviously, as I said, identify the areas of weakness of the individual CNA and correlate that to how you're going to train. So this is a work in progress. This is, I'm very yes, I am remote right now, but I do think that we have the forum to be interactive. And I think interaction is an important part. So if there are CNAs on this webinar, I want you to know that I'm an OT by background. And one of my favorite things to do in the nursing facility is when I would come in early and train the night shift on coding section G and section GG. And I would say the night shift would be so grateful that they were receiving the education and the Dunkin' Donuts munchkins and to hear information, because they were very eager and grateful for knowledge. And in today's society with technology, yes, we have access to it. Just because we have access to information doesn't mean that we're going to penetrate it into our brains. It's that formalized setup that, oh, okay, we've got a good rhythm going with our Thoughtful Thursdays. And, you're getting the information and it's consistent. And that's really important. So how you're training. So what I'm saying is I, as an OT, one of the favorite things is training the CNAs at night. And I, as an OT, did ADLs. And that is the hardest job in the facility, sweating, because hot rooms, washing and bathing, it's a lot of work. Looking at the fact that, and we talk about this with this whole group here, that our mechanisms for education might be different. I'm very quick to pick up on an adult learner if they're better at learning auditorily, visually, or figuratively, or reading. And some people are really, really good at learning just by listening. Other people have to be able to write it down. As they're listening, they write it, and that's how they learn it. So know your audience. And as an adult and as someone with kids, you can pick it up pretty fast on someone and see how they're really pictures, not pictures. So don't think that one forum is better than another. It's all individualized, but that's why it's good to have a variety. And with technology today, to be able to record things and play them back. So I am, as we know, a bona fide ADHD, undiagnosed, but I was a good student. And high school was very easy for me, but college, I was, whoa. But I'm driven. So I would go to my anatomy class in Boston and I would record, not knowing I had ADHD, I would record the class. So I'd, 30 minutes to Boston, Tufts Medical, listen to the class, bus home. Now I would replay it back and I would rewrite my notes and color code them. I had to take the little recorder. So sometimes the recording is valuable for someone that needs to hear it. Other people cannot take notes and listen and they can remember. So the variety of methods that you use, now again, in person, return demonstration, webinars, recordings, on demand, all different mechanisms that you can use. And I urge you to even ask the person, how do you learn best? What do you think is great? Well, I like to watch videos in the privacy of my own home, or I like to read. Everyone has a different mechanism for doing that. So this particular eval that you are going to complete on every single employee, and you're going to identify them, their competencies, and then you're going to put goals in their performance eval. And we're going to look at these things. We're going to learn more about this and have it to be a very productive, interactive process. It also will help with retention. This is just the regulations reiterated to you in a pretty way. But what I do like to point out is that cognitive impairments, dementia, and abuse, they're all connected. And the goal here is to prevent abuse. The goal is that people understand what abuse is, and also that how to interact with someone who has dementia or cognitive impairments. One little thing, a feeding assistant, which by the way, not every state accepts, but if you do have, you cannot use any individual working in the facility as a paid feeding assistant. They must have to have gone through the state approved training program. Also going back, this all started with the Affordable Care Act, and the Affordable Care Act is identified that there was a need for training in the care of patients with dementia and preventing abuse. And that the overarching theme is that with the shortages and with the lack of individuals in this area of dementia, it's concerning to prevent a public health event. Now, a couple of examples that I would like to share. My ex-husband's aunt was in a nursing facility. I'm an occupational therapist. I did direct care in nursing homes. So I was in Connecticut, and he said, my aunt is in a nursing home, and do you think we could go see her? And of course, you know me, I go fast. I'm like, and it's, I don't know, maybe I spoke in Connecticut. I'm like, okay, where is she? And it was 3 hours. And I said, okay, drive there, go. We arrive into the nursing facility, and I found her in a room, a patient area, a room that was a congregation room. She was hunched over and looking down, and she was on the locked unit. I have an advantage, obviously, because I'm in the industry, and she had expressive aphasia. But I knew the details of what was going on in her family dynamics, and she hadn't eaten. She was, a hot mess. She could not give me a full sentence, but I had a full-blown conversation with her. I had sat down with her. She ate her whole meal. I took her to the ladies' room, helped her get changed. She was very young. In my opinion, she was misdiagnosed, and I don't believe she belonged in this setting because she was alert and oriented. If you're not trained, like understanding dementia, expressive aphasia, receptive aphasia, you can misdiagnose a patient. As an occupational therapist, as someone who's been in over 5,000 nursing homes. I've sat on many a dementia unit and looked at medical records with dementia patients sitting next to me all day long. And the approach of, where's my daughter? Where's my daughter? And I have the book and the notes and say, oh, she'll be in at 2 today, very calmly, tone. Because again, now this is a bona fide dementia patient. And as I'm sitting there doing my record reviews, she's next to me and asks me the question every 3 to 4 minutes and having a full-blown conversation with her. And it's the behaviors. Just because someone has dementia doesn't mean they do not understand a raise of the voice, body language. They understand the essence of the conversation. And an untrained individual, it could be quite dangerous not knowing exactly how to approach, discuss, and talk. This particular slide just reiterates the fact that we now have a federal mandate for this. Many states have them, many states don't, but either way, whatever the stricter of the rule is what you follow. And again, this is, I'm bringing in some data from across the country and some from Massachusetts and New York. Then we'll get into some other, but just statistically speaking, 3% of medical students choose geriatrics. I immediately went into geriatrics. I don't know what, I just love, why? Because A, we're all going to get old, and B, I love knowledge. So I told you I'm a knowledge junkie. What better way to get knowledge than go to the source, the people that have been around? They have information. It's gold. Knowledge is gold. And if you have little exposure and you don't understand, you have ageism. You have people that don't understand that my brain and what I think is the same as I thought when I was in high school. But if I considered what my mother was when I was 55, I'd be like, she was the crypt, she was old. But we at 55 don't think we're old, we think we're young. So someone who's at 65 or 75 or 85, they don't think they're old, or they may not think they're old. They could, but I'll never think that I'm old. So it's a mindset. Staffing challenges. I'm only pointing out to you that there are staffing challenges, and there were staffing challenges before the pandemic, so that having the ability to recruit, retain the individuals with this skill set is super important. This particular, when Deval Patrick was the governor of Massachusetts, that's when the House made this law, and it was in 2012. And they said that we would have to make sure that you would have to receive dementia-specific training, all direct care workers. This ties right into the facility assessment. And at that time, about 120,000 people with Alzheimer's live in Massachusetts. I was at the New Hampshire Healthcare event a couple of weeks ago, and there was a fellow that spoke, and he spoke about dementia and Alzheimer's, and he said it's all preventable. All food, activity, all these things. What food is good for me may not be good for you. What activity is good for me may not be good for you. And I say that to you because I always had an aversion to care tracks. What are they called? The plans like, CVA, 12, 14 days in a nursing facility or with rehab. I never ever liked them because I'm like, the patient has so much more going on. It could be a good guide, but this fellow also reiterated the fact how important it is that a diet that's good for you is not good for someone else. Individualized care plans, which this also gets into, because under the behavioral component, it goes under person-centered care, which will be the last section of slides. So ongoing. So you have to think about what is your pattern? What do you want for a pattern? I'm happy to help with that. I'm happy to think about it. And even, I love patterns. So if you have an inflow and an outflow of staff that, on every day or every week or every month, this is when we do the training, just so that individuals will have that knowledge. And they also specifically, we're going to get into the cognitively impaired as well. The other piece that I want to point out to you is that the changing population, does it change a lot or a little? Will your facility assessment, that is why you have to update it every November, because if it changes, then you have to change your training program. Furthermore, if the training program has advancements or new technology or other areas, that would have to be incorporated into your educational program. So we're just going to keep on beating that to a dead horse. So dementia management, resident abuse, cognitively impaired areas. In Massachusetts, they had phases, and basically the surveyors are going to, let me back up. They're going to identify coming into you how you perform your in-service education and how do you address areas of weaknesses. And they're going to also make sure that you are doing that evaluation and how you're determining if you're giving someone additional education and training in that area and how you're going to get it. And then again, this unique resident population. I can go off on this for 3 hours because I'm that nerd that collected data for 3 years and had a backroom database. And this was back in 2012, 2013. And my aha moment was with the first, 1,500 patients, and maybe it was 800. But the point was that I had to have subcategories because they all had different primary diagnoses. So I had to make categories: orthopedic, neurological. So meaning that, how do you define your patient population and how do you describe it? And this is all based on your MDS and the ordering of diagnoses. So it's very easy for you to misrepresent, misdefine. And I looked at a medical record from New York last week, and there were 74 ICD-10 codes. 74. Remember, the surveyors do not need to have a negative outcome to give you a tag citation on this area. So how will the surveyor identify and that whether or not you have an adequate, a competent program? They're going to look at the number of hours completed. So be sure that, and hear me out, organization is a skill set in itself. And I say to you that technology can be helpful, but do not rely on technology to be your administrative assistant. In other words, if you saw, I'm in Minnesota right now, and it's like 23 degrees, by the way. It snowed every day. It's like a bit of a disaster over there on my makeshift desk. But how are you tracking it? Do you have a binder? Do you have an Excel sheet? Yes, there could be great programs out there, but make sure that you have a system in place, and that system, what does it have? Chick-fil-A, right? It has an inherent checks and balances. Someone's going to record it. Someone else has the data, because you cannot make your system rely on an individual. The system has to be the driving force for the outcomes. So you're going to make sure that people have gone through these programs. You're going to have them in different mechanisms, live, et cetera. So they're going to say, where is your program? How do I know how many hours Chris has? Is it a binder? Is it a file? Is it virtual? Is it on your server? Where is it? They're going to observe the nurse aides. They're going to watch them. They're going to observe their companies, because they know what they need to do and whether or not they're understanding it. And when they go to talk to someone, do they get to eye level? When you can't stand when you're feeding someone, you have to have eye contact, leaning in, being a good listener, non-distractible. They will observe the nurse aides. They will interview. They will talk to people. They will talk to you. They will talk to other CNAs. They're going to talk to residents. They're going to ask them. They're going to ask them about, what do you know about hand washing? What do you think about hand washing? Do you got a lot of hand cream around? Because your hand's going to be cracked by the end of the day. And just really very easy for them to see what is happening. Now, there are many people that freeze up when authority figures come in. That's understandable, but they will be asking what's going on. First thing that you need to do is you need to take an evaluation of your current program. Evaluate exactly the pros and cons of it right now. How do you assess competency? Is it a follow-up quiz? Is it a follow-up discussion? Is it verbal questions that you ask? Is it questions within the Zoom? In other words, because you can establish Zooms to have, I'm going to just get 7 questions came in. So figuring out what do you think you're doing well, and what do you think that you need to improve upon? Why does the facility assessment need to be updated every November? I updated mine in May. Do I need to update it again? I think that the facility assessment needs to be updated in November. My opinion is because the fiscal year goes from October 1st until September 30th. And you have the ability by November 1st to look at your last year's data to properly reflect the past year. That is my opinion. And I like it. I like November. And if you updated it in November, great. In May, put that, but I would do a review. And what I mean by that is on the cover, I would put that I reviewed it in November. I do believe the date is November, and you should get on that pattern. Oh, my audio is cutting in and out? If that's the case, I am in a hotel and I am on Wi-Fi. So that could be why. Yes, you can still use the CMS hand-in-hand training for the required dementia training. Absolutely. There's no. Great question. So Robin is saying, can we still use the CMS hand-in-hand training? Absolutely. What you want to know, or you want to make sure, is that it works for you. So there are a lot of programs out there. You can customize them yourself. Whatever you can get out there, you can use. If you feel as though it's effectively working for you, then absolutely use that. Okay, is it 12 hours per calendar year or 12 hours per year based on the hire date? Absolutely the hire date. In other words, so from the time that they start until it should be, and again, that's a tracking piece that and as is their annual reviews. Now, there are companies that will do everyone's annual review in January, and so therefore, if someone started in June, let's just say, then 6 months, they would be on that. You can do it different ways or different questions. The slides are usually the slides are made available within, I would say, within a week, if not sooner. I edit them afterwards, after we have our discussion. And I will give you the slides if you email me, but there is a download that you can get them. Yes, Patricia, I agree. Patricia Ward. Be sure to save sign-in sheets to validate employee attendance 100%. The sign-in sheets are incredibly important, and you do, for CEUs, you need them as well. Thank you, Noah. My audio is fine. I was panicking because what you don't know is before I started, so I have like a jetpack that I carry with me, and I ran out of minutes. So then I went on the hotel Wi-Fi. And of course, this happens right before. So thank you. Okay, so Shelly saying, I'm pretty sure it's just required yearly and you use the last 1 year of the MDS for the assessment. Oh, you mean I think she means the no specific month. I'm not sure. Oh, okay. They're saying, other people are saying that it's okay that your facility assessment was done in May. I believe it has to be done in November. I could be wrong. We'll figure it out, and not a specific month. For some reason, I thought it was November. And let's put it this way. I ensure all our clients do it for November. So, okay. So 336. When you also want to be, those that are on this right now, you're being educated because you could be the ones that are completing the performance evaluations. And this, if anything you gain out of this 60 minutes is that, heck, I have to be sure that I identify their strengths and weaknesses and offer them educational support in those areas as well. So I think that's a win in itself because there's a lot of information coming at you. So overarching theme, 12 hours a year, competency, your ability to evaluate that they were competent, and you're providing these trainings. Now I'm going to go into what I consider the abuse and the dementia training, and I can elaborate on these. With regards to abuse training, there is ABC. There's a facility risk factors, there are resident risk factors, and relationship risk factors. So number one is to be sure that you have an effective abuse prevention policy. You have staff education and training, which we're talking about. You have staff screening. What does that mean? That means that when someone is being interviewed, that you are background check, assessing if they've had a history of any, loss of licensure. And you should be doing that from a compliance perspective. It's your responsibility to make sure that you're not hiring someone who is alleging they have a licensure when they don't, or that they've never been in trouble before and they have. So the staff screening is a high priority. How are you screening out potential employees? The other risk factor is burnout. And I always say to people, you have to take care of yourselves. In other words, we're all of you are you're givers. You're in this industry, you're a giver. And you have to take care of one another and make sure that the giver doesn't crash and burn. The giver crashes and burns, and the house of cards will go falling down. I have 4 daughters. If I'm good, my daughters are good. If I'm not good, my daughters are not good. And it's the most bizarre thing, but you will see if you, the leader, you are in a good place, everyone will be in a good place because you're driving the bus. So make sure that the leaders and the managers are, you go take a day off and you don't. Some people like me, we work a lot. We like to work. It's my nature. It is what it is. Some people have to walk away, and they have to walk away and they come back better when they walk away. I find when I'm creating and I'm doing things that have, or I'm trying to figure out that damn PBJ, and I have my whiteboards, and I figured when I'm going to do one of these from my house, and I'm going to have my laptop, and I'll show you what my whiteboards are, and my activity room with my periodic table. But that piece is so important. And I'm glad that, if you're on this, you're on with other individuals, because you have to take care, figuring out the stressing and the burnout and how to prevent it. It could be scheduling, of course, but it could be other things, because there are 3 P's in life: purpose, play, and perspective. Purpose is what you do every day, in my opinion. Play is, what do you like to do? I don't know what you like to do. Only you know what you like to do. I like to walk, and I like to watch Netflix, and I like to read. So what is the person next to you? What do they like to do? It could be paint, play cards, have a glass of wine. Who knows? Just talk. So figure that out. Perspective. I think all of us have massive perspective in this industry because we see things every day. So we have perspective. I wake up every day going, yay, I'm alive. Yay, I can see. Yay, I can talk. Perspective, right? I'll tell you the story about the girl that wrote a letter to her parents, and she went off to college. She met a man, a boy. Parents met him, did not like him. She fell in love with him. She called her parents, wrote them a letter, and she said, I dropped out of college. I moved in with the boyfriend that they don't like, and I'm living in the basement with his family, and I'm pregnant. And then at the end of the note, she goes, just kidding. I got a D in chemistry. Perspective, right? The parents are like, okay, she got a D. Don't care. Perspective. What is your staff ratio and turnover? As you know, the PBJ has now changed. July 1st, you have your nursing home compare. You have 3 components. You have health inspection domain, quality measure domain, and your staffing domain. And the staffing domain was based on a PPD, hours per patient day. Effective July 1st, it's not just the hours, it's now turnover. So in order for you to get a 5 in the PPD, in the PBJ, the best you can get based on your staffing is a 3, because that's 250 points. So the other areas are going to be on turnover. There is a direct correlation with staff consistency and higher quality care. It's what the studies show. The other facility risk factors for abuse include a history of deficiencies, complaints, culture and management. In other words, what is the expectation here? What is the management? Now, Harmony has done surveys across the country, and I will not tell you this area. The area was, the findings were not good, and residents had dentures in their mouth for 2.5 years that had to be surgically removed. And the culture, in other words, it's about identify how was that missed. It happens, but it's the culture, right? They're going to automatically go to the top. Who's leading this? What is the fastidiousness of the leader of the care and all of that? So they're going to look at that. I mean, that's an abuse indicator. And the physical environment. Don't underestimate the importance of your environment. Now, the lighting, the color, the smell, stairs, no stairs, all of those things matter subconsciously to you and to the people that work there, as well as the residents. Then you have the resident risk factors, and that would go into the fact that they have unmet needs and if they have behavioral or cognitive symptoms. And then the letter C is relationship risk factors, and it's the family members and the resident staff interactions. So let's stop for a second. So on B, resident risk factors would be that if you have a high population of, let's say, DSM-5s, and the DSM-5s are residents with depression, dementia, anxiety, schizophrenia, bipolar. If an individual has a DSM-5, they have a higher likelihood of having interpersonal relationships. The less support you have, the less healthy you will be, for lack of a better term, and the more support you have, the more healthier you'll be, or the longer you'll live. That can play, now that's on, so if a patient has a DSM-5, there are 3 factors that impact someone's longevity. Number 1 is the more medications you take, the sooner you die. The higher the risk that you'll die sooner. The slower you walk, the sooner you die. And if you have a DSM-5, you'll die sooner. And the reason is you have less family support or less social support. And C is your relationship risk factors, meaning if there is a high frequency of visitors in a residence area, there's a tendency for there to be less proclivity for abuse. But it can backfire if you have an overzealous family that comes in. It can cause problems as well. And there's also a risk factor if there's been a historical conflict between a resident and a staff person. That can as well. It is common knowledge that poor staffing can be a breeding ground for abuse. Why? If the person is overworked and there's not enough people to help, they're stressed. And I say this, and I'm going to say this again about therapy. We talked about it with compliance last week. If you are not given the same amount of minutes that you gave in 2018, you're cuckoo for Cocoa Puffs, because that's the first place that I would look if I were the government. And you need therapy. You want therapy in there. It's another set of expert hands, meaning if poor staffing is directly correlated to abuse and neglect, then you need to get more you know, hands on deck. And that's why you should have therapy in there, Medicare Part B program development, involved in your care planning meetings, falls prevention, restraint reduction. The more help you can get, the better. And I also bring in the fact with respiratory therapy. Okay, respiratory therapists will not go into your PBJ. We need to advocate for that. But respiratory therapy is an under-tapped service that you can utilize to help in this situation. So poor staffing is a risk factor. I already listed for you the critical risk prevention factors. I'm just going to pop back so you see it right here on slide 35. Now, but I'm going to talk a little bit more about these other ones. The resident risk factors, as I said, the DSM-5, and obviously these behavioral symptoms associated with dementia and unmet needs. You know, there's isolation. Hearing is a big one. Back in the 70s, the government instituted the mandate about hearing aids. If I can't hear you, I cannot engage. If I can't engage, I'm going to disengage. And if I disengage, then I'll lose my self-efficacy. And remember, there is a difference between loneliness and depression. Loneliness is an epidemic, they say, and there are 3 groups that have the highest risk for loneliness. 1, the vets. Number 2, the elderly. 3, 12 to 18-year-olds. The vets, they need to be with their brothers and their sisters. They need like-minded. That's why the vets do such a good job with the their residents, because they understand it. They understand PTSD better than the non-veterans home. But obviously, for the obvious reasons, they need to be with their brothers. They've been trained. They're accustomed to that. It's a very comfortable environment for them to be in. Seniors have a risk. Number one reason, hearing. If they cannot hear, they cannot engage. If I go and I sign up to volunteer at your nursing home every week, and I come in and I volunteer with Mrs. Jones, and every Friday I see her and she comes up to me. I mean, we sit together, we have our tea, and we spill the tea. That's what the kids say. She tells me all of her issues, and then I leave. Did I do a service to you and your patient or your resident? I did not, because in order for it to be beneficial for that resident, it has to be didactic. And you have to have, she has to bitch and I have to bitch. We have to both go back. It has to be this didactic, and that's how it benefits. And women, men are from Mars, women are from Venus. There's a book on this. Women have more of a likelihood to do that. They call their friend, they just complain. The woman comes home from work and she says to the husband, my boss did this. And then the husband immediately wants to fix it. Men are from Mars, women are from Venus, different personality types. The guy wants to problem solve. The girl wants to complain about it. Not both are healthy, by the way. The point, though, is that loneliness is caused by any individual that does not have not 1, not 2, but 3 individuals in their life that they can trust. And when I talk about capitalizing on community, if you are ever in a shutdown, you can build that 3-person connection with residents for you and for the residents. So just because you're isolated in a facility doesn't mean you can't have the 3. So the 12 to 18-year-olds on the isolation, it's because of social media. It's because of the they have lots of friends, but they don't have the 3 that they can trust. They're superficial relationships. They need to have the 3. And this was learned over a decade ago. And when I told my doctor about it, when I read about it, I'm like, did you know? And he's like, Chris, we learned that a decade ago. I'm like, okay. So, but hey, listen, we're always learning. So behavioral symptoms. Understanding if someone's angry or they're hitting or they're screaming or they're yelling, they're upset because they're not able to express themselves. And it's important, especially with the restraint reduction, the antipsychotropic medication initiatives, that your staff are trained to understand that someone's behaviors are a form of communication, understanding those pieces with it too. So loneliness, depression are two separate things. In the spirit of the staffing mandate PPD and understanding that isolation, that 3-person, this is where you can capitalize on, okay, the same shifts, the same persons, they want that continuity of care. C, what are other risk factors with regards to abuse training is that the family and the caregivers, those that have less visitors are more vulnerable. We know that. You and I know that because we're in the industry. And as I said earlier, the overzealous family could actually cause problems of their own, or their conflict, they can bring the conflict in. And then obviously there's a historical conflict with the patient and the staff member, which you need to be mindful of and monitor and watch. So just going to keep plopping right here. The ability for you to identify vulnerable residents, make them less vulnerable, provide access to them to finding family members, I think is incredibly important. Identifying ways for residents to communicate with family members, promoting it, letters. Don't underestimate the ability to do a phone call, do a FaceTime, encourage communications with others. No one wants to see someone not have someone there for them for a holiday or for a family or for a family event. So the other important part is, having an abuse prevention checklist and ensuring that, you're always observant to see if you're at risk for it. I put this in here because it goes into the requirements of reporting of abuse and neglect. And the key element here is that, as you know, I get called into all the 911s. And wait a minute, Jennifer's raised her hand. I don't know if I know how to do it, Jennifer. 1 second. I will correct this in a second. The reason I'm going to go to your questions in 2 seconds, and I'm going to see if I can see the raised hand. How do I do the raised hand? Let's see. Trying to do the raised hand. Oh, I see the raised hand. I don't know how to do the raised hand. Can you write it in the chat? Just really not sure how to do it. I mean, maybe it's just the polite way that, ooh, someone else raised their hand. Can you not hear me? Someone type if there's something going on. I'm going to say 2 things and I'm going to go to the questions. In the abuse allegations, you have to make sure that you call the appropriate associations and organizations. It's the first thing the surveyor is going to look at. Something bad happened and you have to make sure you do the right steps. And that's why I'm putting these slides in. The PowerPoint isn't on the screen. Okay, I'll try that again. Let me stop the share. And let me share the screen. Okay. Does that work? I'm not sure if that, let me know if that works. Okay, good. Okay, chat is disabled, but Q&A is okay. We can hear you. I can hear you. The PowerPoint isn't on the screen. Is the PowerPoint on the screen now? You let me know. Slides are okay. Thanks. Thanks, Maggie. All right, so facility, I'm going to go back to some questions because I don't want you to lose it. I'm talking about the facility assessment, not the nurse aide training. It's due yearly based on the previous year MDS data. There is no month in the regulation. Okay, very good. Very good. Very good. Thank you. Oh, so Gina, you just can't see them. So the other people can. Gina, were you able to see them and then not see them? Or were you just never to be able to see them? That's the question I have for you, Gina. It's okay. Don't apologize. You're good. It happens. So someone else used to see them and now they can't either. That's bizarre. Let me do it one more time. Sometimes just try that again. Okay. Licensing and certification agencies, the ability for someone to observe you and see how you're doing, they can see so what are the surveyors and what are the outside agencies going to do when it comes to an abuse allegation? They're going to look at your historical deficiency reports. They're going to look at your survey data. They're going to look at your policies and procedures. Do you have, I'm going to give you an example of one of my recent cases. And I think I told you the allegation of sexual assault. I fly in and my team told me that the building was going to be very, not defensive in a bad way, but like, hey, this didn't happen here. So I walk in and I say, I understand. I get it. I said, but if I open the door, the barn, and I see a snake, whoop, fight or flight. And that's how I felt. Oh, it was just a rolled up piece of rope. We still had to train everyone in the facility on trauma-informed care, how to manage this patient. 4 months elapsed. The patient, the police involved, etc. The facility was not charged with it. It did happen in a different setting, but it didn't negate how that resident felt. In other words, the resident felt as though there was a sexual assault on her in this environment. And the staff had to learn how to manage someone that's in that mindset, giving them control over their environment, only having female nurse aides. If they want to get on the elevator, then they have the choice, because giving them control over their environment, that they can say, I want to be on the elevator alone, obviously with the aide, because they have to have that control. In this particular case, the surveyors definitely focused on how they reacted, meaning how did the nursing home react to the allegation? And in your policy and procedure, be sure that you define that you're going to call Department of Public Health in whatever state you're in, put the phone number in your policy. Because this is when you're in the middle of this type of allegation, it's so stressful that you want to know, okay, who do I have to call? What other agency do I have to call? How much time do I have to call? What do I have to do here? So they're going to look at all of that. And I'm also going to tell you from experience, that is usually where the tag goes, because the response of the facility did not hit all the areas, which, by the way, is discussed in the requirement, the 62922 investigative protocol. They're hyper focused on that. So they can look at your policies, they can look at the nurse's notes and records, and looking at the MDS. I'll go back to notes in a second. I have 33 questions. It's okay. Adult Protective Services, that is another one. You have to call them. Whatever your state specifics say, and APS can go in and look at any areas there as well. I'm just gonna make sure I'm not skipping anything for you. Okay, we look there. APS can look at all those areas that I just talked about, and they may have a very strong relationship with DPS or other entities, the ombudsman person, all of that. So there's, understanding what is happening here. And it's a very lousy situation to be in, very stressful, especially when individuals have never been in that position their whole lives as administrators and working it, but know that they're all interchanged and having that allegation as well. So I'm going to just go through and I'll refine these slides as well. I wanted you to know that in the context of dementia training, that it really does go into person-centered training, because it's about training the staff to know what the roles and responsibilities are of each other when caring for the resident, and that the roles may evolve. They may evolve for a multitude of reasons. It could be because of the disease, but also as the patient has a familiarity. So when you're doing dementia training, ensuring that you're educating and showing the staff that this group, i.e. your interdisciplinary team, is working collaboratively on behalf of the patient, and you're trying to extract the specific areas. What do they like to do? What is specific to them? And having everyone on the same board having this information. These are some slides that I will refine for you, making sure that the patient is the patient-centric, and this is good for you too, because in your care, where you have for your healthcare, wherever you go, it's the person-centered care. And I talk about now, like before, you'd have to wait 4 hours and 45 minutes to go see a doctor. Whereas now, maybe they're like, maybe that's a little stressful for someone. So maybe we'll give them one of those little beepers and they can go shop at the mall until their time is up, right? It's not fair to let someone sit there. It's disrespectful. We're all equal and we all deserve the same amount of respect. Care coordination, obviously, listen, do not underestimate the power of organization. And from communication to scheduling to efficiencies, everything plays into it. And just being mindful of the fact that having that collaboration amongst all of you for one patient it's a game changer. And obviously being flexible with the needs, because dementia patients have varying flexible needs. Let me just go through. I just want to go through these 8 elements. And these 8 elements are used in the context of dementia training, developing an individualized goal, ongoing reviews of the care plan as you do, every quarter, or if there's a significant change, developing your team, having a lead, ensuring an active coordination among all providers, always sharing of information, constant education and knowledge, and making sure that you have outcomes, goals. Therapists are really good at doing goals, independent, supervised, whatever they're going to be. And last comment here is developing, getting as much information about their values, their needs. Every person is different, getting the family input, and just getting the goals done. So likes, dislikes, what works, what doesn't work, what time do they like to go to bed? You're used to this, but with a dementia patient, it's much more intuitive, and foods, things that they like. It's a lot more research for you. It's a lot more exploratory for you and your team. So what I'm going to do is, I know that I will, obviously cut this down. I'm going to go to the questions because there are 35. So I'm going to start at the bottom. Okay, Shelley, is there now, I'm going to stop the PowerPoint now so that the recording will be 60 minutes and that people that want to watch it. Do you think I should leave the question and answers on? I'm going to stop the recording, I think. Stop it. Thank you. Okay. It didn't say it stopped. All right. Oh, yes.